All right, so now we're going to start talking about the cardiac muscle and its electrical activity in 19.2. Recall that cardiac muscle shares a few characteristics with skeletal muscle and smooth muscle, so hopefully you're familiar with skeletal muscle and smooth muscle, and you remember that from first semester anatomy and physiology. If not, I suggest going back to the muscular section in the text and briefly looking over that information again. But it has some unique properties of its own, which we'll talk about. Not the least of these is the ability to initiate an electrical potential at a fixed rate that spreads from cell to cell and triggers a contractile mechanism of the heart. This is called autorhythmicity. Neither smooth nor skeletal muscle can do this, but even though cardiac muscle has its own rhythm, its autorhythmicity, heart rate is actually modulated by the endocrine and the nervous systems, and we'll talk about that in a little bit. There are two major types of cardiac muscle cells: myocardial contractile cells and myocardial conducting cells. So contractile, those doing the contracting, and conducting, those conducting the electrical impulses. The myocardial contractile cells constitute the bulk of it, so 99% of the cells in the atria and the ventricles are going to be contractile, those that are contracting. Contractile cells conduct impulses and are responsible for contractions that pump the blood. The myocardial conducting cells then are the last 1% of the cells, and they're the conduction system of the heart, so conducting the electrical impulses. Except for the Purkinje cells, they are generally much smaller than the contractile cells. They have few of the myofibrils or filaments that are needed for contraction. Since they don't need them, they don't have them. So their function is similar in many respects to neurons, even though they're muscle cells. So they can initiate and propagate an action potential, the electrical impulse, that travels throughout the heart and then triggers contractions that are going to pump and propel that blood. So the structure of cardiac muscle, this should be a review from last semester, but compared to the giant cylinders of the skeletal muscle, the cardiac muscle cells, or also called cardiomyocytes, cardio heart, myo muscle, and cytes cells, are considerably shorter with smaller diameters. And they also have striations, which is that alternating pattern of dark A bands and light I bands to the arrangement of the myofilaments and fibrils. So remember, the A bands and the I bands are the overlapping of the myosin with the actin, which are those myofilaments and the other fibrils that are organized into what are called sarcomeres along the length of the cell. So again, remember, go back to your previous chapters if you are not remembering what these different things are. These contractile elements are virtually identical to skeletal muscle cells. So when we're talking about the sarcomeres, we're still talking about the myosin, the big thick myosin with their myosin heads, and those thinner actin, and those filaments overlapping so that they can pull and do a contraction. T-tubules, or transverse tubules, penetrate the surface of the plasma membrane, or from the surface of the plasma membrane, and they dip down into the interior of the cell. Remember that the surface of the plasma membrane, or the plasma membrane, is called the sarcolemma when we're talking about muscle cells, and they allow the electrical impulse to reach the interior, so the interior of the cells. Therefore, the T-tubules are found only at the Z-discs in cardiac cells. In skeletal muscle, they're found at the junction of the A and the I bands. So there are only about 1/2 as many T-tubules in cardiac muscle as there are in skeletal muscle. Also, the sarcoplasmic reticulum stores few calcium ions, so that's another difference for the cardiac muscle. So most of the calcium ions must come from outside of the cells, and we'll see that when we're talking about our depolarization, repolarization, all of those things that we're going to need calcium ions, and most of those are coming from outside of the cell. The result is a slower onset of contraction. There are many mitochondria, providing plenty of energy for the contraction of the heart. Typically, cardiomyocytes have a single central nucleus, but 2 or more nuclei can be found in some cells. So cardiac muscle cells branch freely, so unlike the skeletal muscle cells, which are really, really long tubes, these branch more often. A junction between the two cells is marked by an intercalated disc, so that's also something that's unique to the cardiovascular system, to cardiac cells, is this intercalated discs. We didn't see those in either smooth muscle or skeletal muscle. The intercalated disc helps support the synchronized contraction of the muscle. The sarcolemas from adjacent cells are going to bind together at these intercalated discs. So what an intercalated disc is the sarcolema. So remember the plasma membrane on the outside of the cardiac cell, and the two cells, sarcolemas, are going to come together and bind together at these intercalated discs. And then that intercalated disc is going to support this synchronized contraction of these muscle cells. They consist of desmosomes that hold tightly together. Remember, they are specialized linking proteoglycans. They have fibers going between them to hold the two cells together. Tight junctions, which were kind of spot welds, and a large number of gap junctions. Remember, gap junctions have that space or gap in them that allow the passage of ions between the cells and help to synchronize the contraction. So intercellular connective tissue also helps to bind these cells together. All right, and the reason, of course, that we have all of this to hold these cells together is because we have this contraction or this movement, so it's important that there be a lot of things holding it together to make sure that the heart doesn't rip apart, basically. So here's our image of that. So here we have our cardiac muscle fibers here. We have an individual muscle cell. You can see the intercalated discs in here, which then are blown up here to see the desmosome. We've got our gap junctions allowing things to flow between the cells. So this would be one cell over here and another cell over here. And then remember, this is made by the sarcolemas, or plasma membranes, coming together here. And you can see them up here as well, the intercalated discs. They kind of are wavy throughout. So both cells kind of have this interconnectedness, or this finger when you hold your hands with the two fingers together, they kind of weave in and out. You can also see some of the gap junctions that they're showing here in the intercalated disc region. And then you can see the mitochondria over here. There are lots and lots of mitochondria to provide plenty of energy to the cell. So cardiac muscle undergoes aerobic respiration patterns, aerobic meaning with oxygen. They primarily metabolize lipids and carbohydrates, so they use fats and carbohydrates, sugars, for energy. Myoglobin, lipids, and glycogen are all stored within the cytoplasm. So we have a cytoplasm again, like cells do. They have the cytoplasm, and we have these things stored in there. So we have fats and we have glycogen, so those can be used for breakdown. Myoglobin is muscular, like hemoglobin, which has oxygen and also iron, all stored within the cytoplasm. Cardiac muscle cells undergo a twitch-type contraction with long refractory periods followed by brief relaxation periods. We'll look at that a little bit more closely in a moment. The relaxation is essential so the heart can fill with blood again for the next cycle. So the reason we see the depolarization, repolarization, and the types of refractory periods that we see, which again, refractory period is the period of time where you're not able to have another contraction, is so that the heart has time to fill up with blood, and then we'll have that contraction to force the blood out. But we don't want it filling up, or we don't want the heart to not have enough time to fill up with blood before we start another contraction. So the refractory period is very long to prevent the possibility of tetany, which is a condition in which muscle remains involuntarily contracted. In the heart, of course, tetany would not be compatible with life because it would stop the heart from pumping blood to the system. All right, so let's take a look at the conduction system of the heart. They just make a note here that if embryonic heart cells are separated in a petri dish and kept alive, each one has its own electrical impulse followed by a contraction. So again, heart cells have that autorhythmicity. When these two independently beating embryonic cardiac muscles are placed together, so separately they have their own beat and contraction. If you put them together, then the cell with the higher inherent rate sets the pace. And the impulse spreads from the faster cell to the slower cell to then trigger a contraction. As more cells are added to this, joined to this, the fastest cell or the faster cells continue to assume control of that rate. So it's going to go to whatever cell's the fastest. If a new one is added that is a faster rate, then it will go with that rate. Fully developed adult heart maintains the capability of generating its own electrical impulse triggered by the fastest cells as part of the cardiac conduction system. So we're going to look at those parts, which start with the sinoatrial node. then the atrioventricular node, then the atrioventricular bundle, atrioventricular bundle branches, and the Purkinje cells. So let's take a look at that in the image here really quick. What we're going to be looking at first is our sinoatrial node, or SA node, which is right here. Then we'll be looking at very closely our atrioventricular node, which is where it should be given the name atrioventricular, so between the atrium and the ventricles node. Then we can talk about we will talk about the atrioventricular bundle, or also called the bundle of His, which is right there, crossing over, getting in between the ventricles, which then are going to be the right and left bundle branches, and then down to our Purkinje fibers at the bottom. All right, and we'll look at this again in a moment. So the sinoatrial node, or the SA node, is where our cardiac rhythm is established. It's the pacemaker. It's a special clump of the conducting cells located in the superior and posterior walls of the right atrium, close to the superior vena cava opening, which we just saw. The SA node has the highest inherent rate of depolarization. So we said that the faster cells, the higher rate of depolarization is going to set the pace for the heart. It's known as the pacemaker of the heart. Sets the pace. It initiates the sinus rhythm, or what is called the normal electrical pattern, followed by contraction of the heart. So the sinus rhythm is the normal pattern of the heart, and that is set by the SA node. Then this impulse spreads from the SA node throughout the atria, through specialized internodal pathways to the atrial myocardial contractile cells and the AV node. So the internodal pathways are 3 bands. So we have the anterior, the middle, and the posterior. And then you can actually see those in the image above here. So here's our SA node starting here, and then we have our anterior internodal, which is over here, anterior. We have our middle internodal in the middle, and our posterior internodal, which is posterior, and that's going through the atria. You can see it's going through the atrium to our AV node, so our atrioventricular node. All right, so we were, let's see, internal pathways. All right, so that leads from the SA node to the next node in the conduction system, which is the AV node. So the impulse takes approximately 50 milliseconds to travel between these 2 nodes. The importance of this pathway has been debated because the atrioventricular node simply could follow a cell-by-cell pathway going through the contractile bundle cells of the myocardium of the atria. So they're saying here that people say the SA node is extremely important, along with its 3 bands, this anterior, middle, and posterior internodal pathways. But what they're saying here is that, some people talk about how even if we didn't have these 3 pathways, that the cells would just go cell-to-cell communication and still get to the AV node. So in addition, there is a specialized pathway called the Bachmann's bundle, or the interatrial band, that conducts the impulse directly from the right atrium to the left atrium. So remember, we only have the one SA node, and it has to get to the other atria. Regardless of the pathway, as the impulse reaches the atrioventricular septum, the connective tissue prevents the impulse from spreading into the myocardial cells of the ventricles, except at the AV node. So then it kind of collects all of those impulses at the AV node, and then we can kind of see how that is happening here. We'll look a little closer. So start number 1 here. Actually, I'll go down a little bit more here. So step number 1 is down here. The SA node are at rest here. There isn't any conduction happening here. Then at 2, it initiates that action potential here. So you can see the arrows coming down saying that the action potential is going to go through that atrium here, or atria, because it's going to go to the other side as well. Then 3, after reaching the atrioventricular node, then there's a delay of approximately 100 milliseconds that allow this atria to then contract. So they're pumping blood here at 3 and contracting, and that's where we've gotten so far in our wording here. So we're at rest over here, and then we have the AV, or we have the SA node that starts to send that message to our AV node, which is here in the middle, between the atrium and the ventricle. The electrical event, the wave of depolarization, is the trigger for muscular contraction. So the wave of depolarization begins in the right atrium, and the impulse spreads across the superior portions of both atria and then down through the contractile cells. The contractile cells then begin contraction from the superior to the inferior portions of the atria, pumping the blood down into the ventricles. So again, we're starting at the top of the atria and then pushing that blood down into the ventricles. And then we get to our atrioventricular node. So our atrioventricular node is this second clump of specialized myocardial conductive cells located in the inferior portion of the right atrium with the atrioventricular septum. The septum prevents the impulse from spreading directly to the ventricles without passing through the AV node. There is a critical pause before the AV node depolarizes and transmits the impulse to the atrioventricular bundle. So this delay is partially because of the small diameter of the cells in the node, which then slows the impulse. Also, conduction between nodal cells is less efficient than between conducting cells. Okay, so we're talking about between the nodal cells not being as efficient as being between the conducting cells, the ones that can conduct the impulse. So these factors then mean that it takes the impulse approximately 100 milliseconds to pass through the node. So the node cells are slower than conducting cells. This pause is critical to heart function because it then allows the atrial cardiomyocytes, the cells in the atria, to complete their contraction, pumping the blood into the ventricles before the impulse is then transmitted to the cells of the ventricle. So it gives the atria enough time to pump the blood down into the ventricles. With the extreme stimulation by the SA node, then the AV node can transmit impulses maximally at 220 per minute. This establishes the typical maximum heart rate in a healthy young individual. So of course those that are damaged can do it at higher rates, but it would not effectively pump blood. So we wouldn't be getting enough blood into the heart and then enough blood into the system at that rate. Then we have our atrioventricular bundle, or bundle of His, bundle branches, and then Purkinje fibers. So arising from the AV node, we have our atrioventricular bundle, or our bundle of His, proceed through the interventricular septum before dividing into our atrioventricular bundle branches. So commonly they're called the left and the right bundle branches, and we saw that in our image here. So we went up here. Let's see, so we went to our AV node, so our SA node is up here, our AV node is here, then we go through right here our atrioventricular bundle, or bundle of His, moving down here, then we have our right and left bundle branches, so left and right bundle branches, and then we get to our Purkinje fibers. Also, the left bundle branch has two fascicles. The left bundle branch supplies the left ventricle, the right bundle branch, the right ventricle. Since the left ventricle is much larger than the right, the left bundle branch is also considerably larger than the right one because it has more muscles, it has more muscle cells than it has a bigger bundle branch. Portions of the right bundle branch are found in the moderator band. Remember, we only saw that in the right side of the heart and the right ventricle, and that supplies the right papillary muscles. Remember, those papillary muscles are connected to the chordae tendineae, pulling that valve closed. Because of this connection, each papillary muscle receives an impulse at approximately the same time, so they begin to contract simultaneously just prior to the remainder of the myocardial contractile cells of the ventricles. So this allows tension to develop on that chordae tendineae prior to ventricular contraction. So it's going to cause tension on there so that that valve is being pulled on, and then as the ventricles contract, it's not going to allow blood to go back up into the atria. There's no corresponding moderator band on the left. Both bundle branches descend and reach the apex of the heart where they connect with the Purkinje fibers. It takes about 25 milliseconds. So the Purkinje fibers are additional myocardial conductive fibers that spread the impulse to the myocardial contractile cells in the ventricles. They extend throughout the myocardium from the apex of the heart toward the atrioventricular septum and the base of the heart. So they wrap around those ventricles from the point of the heart all the way around to the septum and the base of the heart. The Purkinje fibers have a fast conduction rate. The electrical impulse reaches all of the ventricular muscle cells in about 75 milliseconds. Since the electrical stimulus begins at the apex, the contraction also begins at the apex and travels toward the base of the heart. So similar, it's saying here, to squeezing a tube of toothpaste. So it starts at the point at the bottom and it squeezes up toward the atria, which is forcing the blood out of those ventricles up through the aorta and the pulmonary blood vessel. All right, so the total time, this allows the blood to be pumped out of the ventricles and into the aorta and the pulmonary trunk. The total time elapsed from the initiation of the impulse to depolarization of the ventricles is approximately 225 milliseconds. I'm not concerned that you memorize all of these millisecond amounts. I'm more concerned that you understand where the contraction is going, or where the electrical impulse is going, and then where we see the contractions. All right, so if we take a look at membrane potentials and ion movement in these conductive cells, we're now going to be taking a look at what this impulse really means, like how this impulse works in the heart cells. Remember action potentials from your muscular system in last semester. They are, however, considerably different between our cardiac conductive cells and the cardiac contractive cells. So remember, we have those two types of cells in the heart, and we'll look at both of them. While sodium and potassium play essential roles, calcium is also critical for both types of cells, and we already talked about that briefly. Unlike skeletal muscle cells and neurons, the cardiac cells do not have a stable resting potential. So you may want to refresh yourself on action potentials, including resting potentials and depolarization and repolarization in the muscular system in the first semester at the beginning of your text. And then as a refresher, go through that, and then we can see here the little bit of a difference we see in the cardiac tissue. So the conductive cells contain a series of sodium ion channels that allow a normal and slow influx of sodium ions that causes the membrane potential to rise slowly from negative 60 millivolts up to about negative 40 millivolts. So that's kind of, if we're starting down here, what we see is this slow influx of sodium. So we're at our negative 60 here, and we see this slow influx of sodium up to right here, which is our negative 40 millivolts. Because of this movement of sodium ions into the cell, influx into the cell, then once we reach this negative 40, this is going to create what's called a spontaneous depolarization, or a pre-potential depolarization. So at this point then, this is this point here, we have a rapid influx of calcium, and then we see this depolarization going up. So we're going from our negative numbers here, negative millivolts, all the way up to our positive numbers here. And so what we see is these calcium ion channels are opening, allowing calcium into the cell, and then it's going to further depolarize it, so a sharp increase there, spontaneous depolarization, until it reaches about positive 5 millivolts. At this point, so at the top here, we see that the calcium ion channels close, and then our potassium channels are going to open. So we then have an outflux of potassium, which results in our repolarizing of the cell, so repolarization. When the membrane potential reaches about negative 60 again, so back kind of where we started, then the calcium, or the potassium channels are going to close, and then our sodium channels are going to open again, and we get us back to the beginning again. So this is one whole section here. Then we have our sodium coming in and coming in and coming in, and then we're going to see that spontaneous depolarization again, followed then by our repolarization. All right, so then this phenomenon explains the autorhythmicity properties of cardiac muscle. So this, what we were just looking at here, this right here is showing us our let's see, I'll even get the words here, our action potential at the SA node. So this is one of our conductive cells, okay? So those that conduct an electrical impulse at the SA node. And then we're going to talk about our other cells, right, our contractile cells, okay? So that's what we're talking about now, our membrane potentials and ion movement in the cardiac contractile cells. What we just talked about are those that are going to have that voltage going through them. We have our diffraction, refraction, and the opening and closing of the channels. And then here we're going to talk about our contractile cells, the ones that are actually doing the squeezing. So there are very different electrical patterns in the contractile cells because they're not the ones that are propagating that action potential. They're not carrying that forward. Therefore, we have a rapid depolarization followed by a plateau phase and then repolarization. So in this case, we have a plateau phase versus in the other cells we did not. This phenomenon accounts for the long refractory periods required for the cardiac muscle cells to pump blood effectively before they are capable of firing for a second time. So again, remember, we want to give time to the heart to fill up with blood before we then send another impulse and squeeze out that blood again. These cardiac myocytes normally do not initiate their own electrical potential, but then wait for the impulse to reach them, right? Because these are our contractile cells, not our conductive cells. Our contractile cells demonstrate a much more stable resting phase than our conductive cells at about negative 80 millivolts for the cells in the atria, negative 90 millivolts for those in the ventricles. Despite this difference, other components are pretty much the same. In both cases, when they are stimulated by an action potential, we have our voltage-gated sodium channels that are open, beating the positive feedback mechanism of depolarization. Then the rapid influx of positively charged ions raises the membrane potential to about positive 30 millivolts, at which point then our sodium channels close. Then we have our rapid depolarization period lasting about 3 to 5 milliseconds. It's followed by the plateau phase, in which the membrane potential declines relatively slowly. So again, we have that potential, or we have that plateau phase in our contractile cells where we're just allowing things to go nice and slow as everything is moving. This is due in large part to the opening of the slow calcium channels. Okay, so we have the calcium channels that are slow, that are allowing calcium to enter the cell. And then there are only a few of our potassium channels that are open, that are allowing potassium to exit the cell. This plateau phase, about 175 milliseconds it lasts. Once the membrane potential reaches about 0, the calcium channels close and then potassium channels open, allowing the potassium to exit the cell. Then the repolarization is lasting about 75 milliseconds. At this point, the membrane potential drops until it reaches resting level once more, and then the cycle repeats. So why don't we take a look at that in an image here. So here we have our influx of sodium. Right here we have our voltage-gated ion channels are open. So we see sodium here, and then we see the sodium channels are going to open, and then we see this sharp increase here going up to positive. So here's our negative 90 for the ventricles, and it's going to rapidly depolarize all the way up to about our negative or positive 30. And then at this point, our sodium channels are going to close, and then we have our slow calcium channels are open. And since they're open, we have our potassium channels as well. We're going to see a slight negativity here. This is our plateau. Then we have our slow calcium channels close right here, and then we see our repolarization going down here. And that's when we have our potassium channels are open, allowing potassium out of the cell. And if potassium is leaving the cell, then our positive is going to leave the cell because potassium is positive, and then we are going to see a very sharp decrease then into our negative 90, or to our negative 90 millivolts again. And then we're going to take a look at our refractory periods here, I guess, in a moment. Here we go. So the absolute refractory period for the cardiac contractile muscles is about 200 milliseconds, and the relative refractory period is about 50 milliseconds. So a total about 250 milliseconds. Again, this is an extended period, which is critical since the heart muscle must contract to pump blood effectively, and the contraction must follow the electrical events. Without an extended refractory period, then premature contraction would occur in the heart and would not be compatible with life. So we see our absolute refractory period here, which is the period of time when we absolutely cannot get another contraction. We cannot send another message to these cells and cause them to contract and push blood. Then we have our relative refractory period, where it's going to have to take a pretty significant impulse in order to get past this period. And then this gives us our total refractory period here. The absolute refractory and the relative refractory is our whole refractory period. And again, that period is when, even if an impulse is sent to these cells, they will not contract because they just can't. They don't have the situation, the correct things are not open. They don't have the negative millivolts that they need at this point to be able to go through another contraction. All right, so we can talk about the importance of calcium ions. Calcium ions play two critical roles in the physiology of cardiac muscle, and we've already seen that we have an influx of calcium through these slow calcium channels, which accounts for that prolonged plateau phase and the absolute refractory period that allows the cells to function. And then the calcium ions also combine with troponin in the troponin-tropomyosin complex. And this complex, remember, removes the inhibition, so it moves out of the way, moves other molecules out of the way, prevents the heads of the myosin molecules from forming those cross bridges with the active sites on actin. And then it provides that power stroke of contraction. So again, maybe go back to the muscle section if you're not familiar with this. Remind yourself of those little tiny kind of hand things, the heads of the myosin molecules that form cross bridges with the actin molecules, thus the active sites on the actin, and then pull to create that contraction. So calcium is important for those slow calcium channels to allow for that plateau period, for one, and then two, it combines with troponin to make the troponin-tropomyosin complex that removes the inhibition, okay, that prevents the heads from forming cross bridges. So it makes sure that the myosin heads can attach to the actin in order to pull them and cause a contraction, which is identical or virtually identical to those in skeletal muscle, which is why I'm referring you back to the muscular section if you're not familiar with that or if you need a refresher. Approximately 20% of the calcium required for contraction is supplied by the influx of calcium during the plateau phase. The remaining is released from storage in the sarcoplasmic reticulum. All right, so let's take a look at our rates of conduction system firing. So the pattern of prepotential or the spontaneous depolarization, as seen in the SA node, followed by that rapid polarization or rapid depolarization and then repolarization that we saw in the SA node, and a few other conductive cells in the heart. Let me back up here. So the pattern of this is we have a spontaneous depolarization followed by a rapid depolarization and repolarization seen in the SA node and a couple of other conductive cells. Since the SA node is the pacemaker, again, it reaches that threshold faster than any other component, which is why it's the pacemaker. It will initiate impulses spreading to the other conducting cells. So then the SA node, without nervous or endocrine control, would initiate a heart impulse at approximately 80 to 100 times per minute. So if we didn't have any endocrine system working on the heart, and if we didn't have any nervous system working on the heart sending messages, then it would just beat on its own at 80 to 100 times per minute. Although each component of the conduction system is capable of generating its own impulse, the rate progressively slows as you proceed from the SA node all the way down to those last Purkinje fibers. So without the SA node, the AV node would generate a heart rate of about 40 to 60 beats per minute. So if we took out or took away the SA node, if it stopped working, we would still see that the AV node would generate a heart rate of 40 to 60 beats per minute. If the AV node were blocked, then our atrioventricular bundle would fire at about 30 to 40. Bundle branches, 20 to 30. Purkinje fibers, 15 to 20. And then that's not stuff here. This part is talking about how some people, highly trained aerobic athletes, can have heart ranges at about 30 to 40 beats per minute. But for most people, rates lower than 50 beats per minute would be a condition called bradycardia. So there's not enough blood pumping through. And if it falls much below that, then it wouldn't be able to get the flow of blood to our vital tissues, and then it would actually result in unconsciousness or death if it goes on for too long. So basically the point in this section is that we cannot rely on just, for example, our Purkinje fibers, because they only beat at about 15 to 20 impulses per minute. We couldn't rely just on our bundle branches. We couldn't rely just on our atrioventricular bundle, because all of these would not be enough contraction in order to sustain life. Here, our AV node can help us to sustain life long enough to then get help, but only the SA node is going to be our best option, and then our backup is our AV node. So if we're talking about these things, I didn't go into detail about the AV node specifically because we're going to talk about if we don't have that SA node, if it is blocked. So our electrocardiogram is our ECG, also sometimes called the EKG, from the German term for cardiology, which starts with a K. So here it's the ECG. So analysis of our ECG reveals a picture of both normal and abnormal heart function. So it's something that we use to see how the heart is functioning, because it's going to pick up on electrical signals that are being sent in the heart. The standard electrocardiograph, or ECG, uses 3, 5, or 12 leads. So the greater the number of leads it uses, the more information the ECG provides. The term lead may be used to refer to the cables from the electrode to the electrical recorder. So it's where these leads, or these sticky pieces, are stuck on the person, and then it's connected to a machine that's reading them. But it typically describes the voltage difference between two of the electrodes. So when we talk about a 12-lead ECG, it uses 10 electrodes, and they're placed on the patient's skin. And we'll see right here in this image where those would be placed. So here it is in the front, and of course the heart would be back in here. So we've got these leads placed on the chest, placed on the arms, and then down here we have them placed on the ankles as well, on the legs. So a normal ECG tracing is up in that image that we just saw. So each one of those dots is going to be where a lead would be placed. So each component, segment, and interval is labeled and corresponds to an important electrical events, demonstrating the relationship between these events and the contraction in the heart. So there are 5 prominent points on the ECG. We have the P wave, the QRS complex, and the T wave. So those are our 3 main pieces. So our P wave, our QRS complex, and the T wave are 3 kind of chunks, as they're called, leading to our 5 prominent points. So P, then Q, R, S, and T. So the small P wave represents depolarization of the atria. Okay, so when we see that sharp increase there on the chart, getting us to positive, the atria then begin contracting about 25 milliseconds after the start of the P wave. Then we have our large QRS complex, which represents the depolarization of the ventricles. So when we see that sharp depolarization, that going to positive of the ventricles, which requires a much stronger signal because of the size of the ventricles compared to the atria. ventricles begin to contract as the QRS reaches the peak of the R wave. And then lastly, we have our T wave, which represents the repolarization of the ventricles. As a note, the repolarization of the atria occurs during the QRS complex, but you can't really see it because the QRS complex itself masks over it because it's so much larger. So before we continue with the words here, let's take a look at that on the image. So we have our P wave here, we have our QRS complex, and then we have our T wave. So our P wave, again, is relating to, and I think there's an image up here, relating to our atria, maybe not, relating to the depolarization of our atria. And then we have the QRS complex, which is the depolarization of the ventricles. And then the T wave is our repolarization of the ventricles. So P wave is the depolarization of the atria. Our QRS is the depolarization of the ventricles. And then our T wave is the repolarization of the ventricles. And so then we see our contraction of the atria here. We see our contraction of the ventricles here. So then going back up to the words and describing these intervals and segments. So the major segments and intervals of an ECG tracing are on that. The segments are defined as the regions between two waves. So segments are defined as that section, kind of like the leveling off period between two waves. And then we have intervals, which are one segment plus one or more waves. So for example, our PR segment begins at the end of the P wave and ends at the beginning of the QRS complex. So a segment is between the waves. Our PR interval then starts at the beginning of the P wave and ends with the beginning of the QRS complex. So it includes the P wave and includes the segment between the P wave and the QRS complex. The PR interval is more clinically relevant, so the interval is more relevant, meaning the one that has the wave and the section between the two, the segment, as it measures the duration from the beginning of atrial depolarization, which is the P wave, to the initiation of the QRS complex, which would be then the contraction of the ventricles. So since the Q wave may be difficult to view in some tracings, the measurements often all the way to our R point that's more visible. So we'll look at that in just a moment. But if there's a delay in the passage of the impulse from the SA node to the AV node, then it would be visible on this PR interval. We'll see differences in that interval. So if we have issues going from our AV node to from our SA node to the AV node, then we'll notice it in this interval here. So again, this is the depolarization and then contraction of our atria, and then this would lead to our depolarization, contraction of our ventricles. And in this area here, our PR interval is when we're going to notice differences there. All right, let's skip that for a moment and go to the next part of the chapter here. So we're going to talk a moment for why that ECG is important. And so one of the reasons it's important is to detect an interruption or a heart block in normal conduction. So if there's a problem with normal conduction, we're going to see that interruption, and that's called a heart block. So the nomenclature for these is very straightforward. The SA nodal blocks occur within the SA node. AV nodal blocks occur within the AV node. The infrahysian blocks involve the bundle of His. So bundle branch blocks occur within either the left or the right atrioventricular bundle branches. Hemiblocks are partial and occur within one or more fascicles of those atrioventricular branches. So clinically, the most common types are the AV nodal and the infrahysian blocks. So let's talk about these blocks. The AV blocks, let's talk about those, and we can actually look at images of those ECGs. They're often described by degrees. So there's a first degree block, a second degree block, and then a third-degree block. So first let's see the first-degree block, also called a partial block. So that's going to indicate a delay in conduction between the SA and the AV nodes. So it's a partial block, but it's still getting that information through. So we're getting from our SA node to the AV node, but it's just partially blocked. So this can be recognized on the ECG as an abnormally long PR interval. So remember, that's from the depolarization of the atria to our depolarization and contraction of the ventricles. So if that's delayed, then we may have this partial block. In a second degree or incomplete block is when we have some impulses from the SA node are going to reach the AV node and then continue on, while others do not. So in this case, the ECG would reveal some P waves not followed by the QRS complex. So we would have a P wave, a depolarization, so the SA node would go, but then it wouldn't get to the AV node, so we wouldn't have a QRS complex. But then the next time we have a depolarization of the atria, our SA node is working, it will actually get through to the AV node, and then we'll see the ventricles contract. Then our third degree is also a complete block. So there's no correlation between atrial activity, so the P wave, and ventricular activity, which is the QRS complex. So even in the event of a total SA block, the AV node will assume the role of pacemaker and continue initiating contraction. So remember, again, we said that our AV node can do its own thing. It has autorhythmicity. It can have its own pace, and that pace is the 40 to 60 contractions per minute, which allows us to maintain consciousness and then get help. Second and third degree blocks are demonstrated on this ECG up here. So let's take a look at those really quickly. So if we go up here, we can see our second degree block up here. So here's our second degree block. So remember, in our first degree block, we still had transmission, but it was delayed. Here, our second degree block is our partial block. And remember, so we have some P waves that do not have QRS complexes after them, and then we have some P waves that do and look normal. And then we have another P wave without the QRS, and then another P wave with it. So sometimes it's getting through, sometimes it's not. So that's a partial block. Then if we look down here, we have our third degree block. And in this case, we see not much that resembles our typical ECG. So some impulses are initiated. We can see some impulse to our QR complex, our QRS complex. We see some here of our P wave, some QRS complex, but it's not in a typical pattern. So the P waves are not followed by our QRS complex, so we're not getting the correct pace. We're seeing the SA node partially coming through, getting some P waves perhaps. We say our AV node then doing its own thing. All right, so then when arrhythmias become a chronic problem, the heart maintains a junctional rhythm, which originates in the AV node. So in order to speed up the heart rate and restore its full sinus rhythm, a cardiologist can then implant an artificial pacemaker. So if we have a serious problem there, it can go in, have some heart surgery, can get a cardiologist to implant this artificial pacemaker, and then that's going to deliver those electrical impulses to the heart muscle and ensure that it continues to contract and pump blood effectively or efficiently. And they can be programmed by cardiologists. They can provide stimulation temporarily, on demand, or on a continuous basis. And some even contain built-in defibrillators so that if the heart does stop, it can be jump-started. All right, so lastly in this section we'll talk about cardiac muscle metabolism. So normally cardiac muscle metabolism is entirely aerobic. So it's right next to the lungs. We've got our oxygen from the lungs brought to the heart and every other organ, and it's attached to hemoglobin molecules within the erythrocytes. So we're getting blood in the heart. Of course, it's pumping blood. It's going all around the heart. So the the cardiac cells are getting oxygen from the hemoglobin molecules in the red blood cells, which comes from originally the lungs. They also store a lot of oxygen in myoglobin. So remember, we saw myoglobin in our cytoplasm, and that also stores oxygen to make sure there's plenty of oxygen for these cells so the heart can continue beating. Normally these two mechanisms, circulating oxygen and the oxygen attached to the myoglobin, can supply sufficient oxygen to the heart, even during peak performance, so even when we're really pushing it. Fatty acids and glucose from the circulation are broken down within the mitochondria to release energy in the form of ATP. So just like all the other cells, we break food down and we make ATP. Same thing in the hearts. Mostly we use these fatty acids and then glucose. Both fatty acid droplets and glycogen. Remember, glycogen is our long chain form of glucose that we store. It's stored within the sarcoplasm, so the plasma membranes of the heart cells, and provide additional nutrient supply. Okay, so we have storage of both fatty acids and glycogen stores so that we can feed our cells even if we're not getting that in circulation. And then we also have our myoglobin, which is stored up oxygen in our cells, so we can oxygenate our cells if for whatever reason we're not getting that. So the heart is pretty self-sufficient in those ways. All right, next we're going to move on to our 19.3, and we're going to see our cardiac cycle.